Good morning from the annual meeting in San Diego. We're pleased to be here today with Dr. Boris Malyugin. Thanks very much, Boris, for being with us today.
Pleasure.
Boris, I'd like to speak with you this morning about a really important topic, and that is capsular complications during cataract surgery. I think that as surgeons, we have become so fortunate to be able to use great equipment and great technology in the OR, yet we still encounter capsular complications sometimes. What are some of the causes of those complications, and how can we possibly avoid them?
There are many causes of capsular complications. One of the major experience of the surgeon. We know that experienced surgeons are much less prone to capsular complication than, say, residents or younger surgeon. The other cause is the cataracts. So we know that with white cataracts, with brown cataracts, we have much more capsular complications than that. That's why not everybody likes to do these cataracts because it's definitely a risk factor. Comorbidity, zonular issues, thickness of the capsule are also influencing, and also technique of the surgeon, which is also the factor that is massively influencing the rate of complication.
Of course. I want to shift gears and speak for a moment about a very interesting technology that you've employed that involves intraoperative OCT, and that helps us to evaluate the capsule during the surgery. Can you explain how that works?
Yeah, with intraoperative OCT, we can observe the capsule and its behavior during the cataract procedure. And we were very much interested in that technology because we observed microparticles located behind the posterior capsule, and we were wondering where are they located. And it turned to be that they are located in the space in between the posterior capsule and anterior hyaloid membrane because vigor ligament is detached from the posterior capsule. And what happened in that? In that case, when nothing is holding the posterior capsule, it becomes a membrane. And with that membrane, so the pressure is equalized below this membrane and above this membrane. So the capsule is not having this curved shape as we want it to be, because when it's curved, so we have easy access to the equatorial cortical material, and we have a capsule that is further away from the irrigation aspiration. When the capsule is planar, that happens with vigorous ligament detachment. So you can easily touch it with the ultrasonic vibrating needle, or you can touch it with irrigation aspiration. You can actually suck it inside, and that makes complications. So this is things that we were never thinking about, how the things that are located behind the capsule can create problems to the surgeon.
So is the OCT, Boris, able to detect whether the anterior hyaloid face has separated from the posterior capsule before the surgeon even starts the surgery, or is this something that's monitored in real time to see if that event occurs during the phacoemulsification?
Unfortunately not. We are not being able to detect it before the surgery, at least with the current technology, or maybe because the cataract is having some space, and even if there is a detachment, so it's not easy to visualize it.
Right.
So we actually understand it during the surgery, mostly after the most of the lens being debulked or removed, and the surgeon is doing irrigation aspiration phase of the procedure, which is, we know, 30% of capsule ruptures occurs during irrigation aspiration phase of the procedure. So if we can make it safer, that's a substantial decrease of complication.
That's a great point, because I think a lot of surgeons, myself included, sort of sigh a breath of relief once the nuclear disassembly portion is completed, saying, oh, well, it's all easy from here. But you're right in saying that during irrigation and aspiration, there still is a substantial capsular complication rate, and it sounds as if this technology may aid us in understanding a bit more about how that happens.
I fully agree with you, and I'm consider myself experienced surgeon, and by the way, most of my capsule rupture occurs during the irrigation aspiration, not during the nucleus disassembly or removal procedure. This is because actually you feel relieved, you feel relaxed, and then you see that the capsule is now aspirated. Of course, you can react, you depress the pedal and release the capsule. However, it's not it's not always the case.
Well, Boris, thank you so much for sharing your expertise with us today, and it's exciting to hear about intraoperative OCT that can help us to understand capsular complications. Thank you for being with us, and thank you to our audience for viewing and supporting us. Thank you.
Thank you for having me.